So it's my very distinct pleasure and honor to introduce our next Tech Talk speaker, Dr. Stefan Schultz, who holds the academic rank of Assistant Professor at UPMC Children's Hospital Pittsburgh. Dr. Schultz completed his medical training in Germany, after which he did his pediatric surgery fellowship at Johns Hopkins under Dr. Columbani. He then followed that with a second fellowship in hepatobiliary surgery in Birmingham Children's Hospital. His clinical practice follows the full spectrum of pediatric surgery with specific focus on MIS, hepatobiliary surgery, thoracic, and colorectal. He has also been the founding chair of multiple ultrasound-focused courses for surgeons and has published a textbook in that regard. I'd like to invite Dr. Schultz, sorry, my next slide is not going, to talk about regional anesthesia for the practicing pediatric surgeon. Please help me welcome Dr. Schultz. Press hard.
Forward. Good morning. Tough to follow, the young investigators, I must say, and change gears completely and talk about something very different. Although it does piggyback to some of the things which were just discussed. And I'm sorry, I have some slides on that, and I hope it's not too boring. I'm going to go over them fairly quickly. But I'd like to thank ABSA to invite me to give this talk here, and it's a clinical talk, and you'll see hopefully something to take away for you. No disclosures, and just press hard. Okay, so the learning objective today is really to learn surgeon-performed regional anesthesia techniques you can use in the operating room with the final goal of obviously saving opioids or reducing pain, for our patient. A good clinical practice, essentially. That's more or less the learning going today. It's not a skills course, it's just discussion of the techniques and a kind of a demonstration. We heard about the opioid epidemic a lot as a public health crisis. We did not hear that 80,000 Americans are still dying every year of this, and the number is actually increasing for several reasons. And neonates, as well as our patients, are actually particularly vulnerable, potentially, to opioids. And deaths have been increasing in this area, adolescents especially too, from this. I put this up more or less for the international crowd who may not be aware of this, but the US is obviously by far the highest user of opioids overall, as well as pain medication. But when you look at the paragraph on the right, the curve, the recent death increase is more or less from synthetic opioids, so fentanyl made often in Mexico, but sold on the street for very little money. But when you look at the curve in the center, the prescribing practices of surgeons or medical providers overall have diminished a little bit, but not a lot. I mean, there's not a really big dent, I see. So it is ongoing public health crisis, essentially, as we heard before. There's been a little more focus on children and adolescents recently, and there's some publications out on this. They're saying, if they're exposed, they may be more prone to become dependent later. Surgery is really one of the sources for opioid in the household, which may be accessible to adolescents later. And the numbers, which I personally am aware of, I guess I'm ignorant to that, but can be up to 20% of our population, children, adolescents, that can have a problem with this later. And I don't prescribe really opioids much or at all. I have really never. Dr. Kelly Kwon, she was the main author on this particular recent paper, which was actually a group of you who prescribed guidelines or published guidelines for opium prescribing for children and adolescents, because there's very little out there in this. This was just recently published, and they recommended in this publication, which was an overview in the guideline, targeted use of perioperative regional anesthesia techniques as part of your opioid-sparing kind of strategy in the operating room. And this can be obviously the epidurals, the ultrasound-guided pain blocks, but those can be also surgeon-provided regional anesthesia techniques. And that's what I want to focus on my talk today. Obviously, the practices are very different. We practice on the high-end children's hospital with a real robust pain team, anesthesia pain team, who does a lot for you. Some hospitals may not have this at all, and the surgeon really has to provide, the peri-operative regional anesthesia by local injections or other techniques. And, I took part in skills courses of the college recently, the American College of Surgeons, which was mostly attended by adult surgeons, where we taught actually regional anesthesia techniques. And it was quite amazing what different the environments are. People who practice alone in the countryside, the rural environment, they don't have access to the high-end pain teams we sometimes have in kind of the big children's hospitals, who can be very helpful. So they're on their own. Minimal invasive surgery we employ more and more to save essentially opioids and reduce pain. And then the regional peripheral nerve blocks, traditionally provided by the pain providers, the anesthesia-trained pain doctors. And then obviously we employ more and more protocols based on the ERAS principles to get patients quickly out of the hospital, save opioids and other things. So that's all something you have to essentially employ. Peripheral nerve blocks, that's what the anesthesia people do under ultrasound. But we use a lot of those, can do a lot of those. Easily, actually. We use field blocks, that's the local injection of a region. Landmark-guided techniques, if you blunt your needle and you do an inguinal block, many people do this. Adult inguinal hernia centers, they rely on those techniques a lot and don't prescribe opioids almost. Thoracoscopic-guided intercostal nerve blocks, potentially cryoablation, we use that a lot. I don't send any PECtus patient really home anymore with opioids, usually on post-op day 2, here and there 1. There's pectoralis nerve blocks, which has really changed the practice of breast surgeons. And I think pediatric surgeons don't use this often, but breast surgeons use those techniques themselves in the OR and send their mastectomy patient home on the same day because of it. And then there are some surgeons who use ultrasound actually for nerve blocks, depending on their practice again. I mean, if your anesthesia provider does it, you don't do it, but in some practices they may have that and may have learned this. One of my colleagues does that in the operating room. And then there are laparoscopic guided techniques, and that's what I want to focus on today, because those things are very easy to learn for facile surgeons like you all are, because you already have the skills. So it is very important when you do any of those nerve blocks yourself to educate the patient and the parents. It's really important. You need to set expectations. You explain to them what it is. It also communicates empathy. I mean, I love if the anesthesia pain team says, I'm the pain doctor. I'm going to reduce the pain. I'll make sure you have no pain or minimal pain, and I do this and this. And we can do the same if we employ those techniques ourselves. There's a really heavy psychological component. And if you go there and say, I care about your pain with this surgery, we will treat it and we'll make sure you have no pain. This is very strong. And it's also important to document this in the op note if you do something, because the PACU nurses, they look at this op note, and if they see there was a pain block, a nerve block being done, they have a totally different attitude towards the patient. The fentanyl or the morphine they're giving, they kind of reevaluate this if they have to. And obviously, in the informed consent, you should describe the block to the patient and kind of put it in the consent, just like the anesthesia pain team does, similar. Potentially mention complications, but you'll see complications generally are low in number. Very important is this picture of the anatomy. And I'm not sure if we all know this picture somehow, but we maybe forgot about it. And you see the anterior nerve, which runs to the cutaneous nerves, the anterior and the lateral cutaneous nerves, runs between, in the abdominal wall, transversalis abdominis muscle and the internal oblique muscle. That's the area where you want to put your local. And then enters the rectus sheath in the center and runs to the posterior rectus sheath and then penetrates more or less to the anterior abdominal wall. And this is just a similar picture where you see the anterior nerves, the lateral nerves, and really the segmental nerves coming in this plane between transversus abdominis muscle and internal oblique. Equipment, this is pretty straightforward. You need a small needle. Sometimes I use the TUI needle, which we use for inguinal hernia repairs, minimally invasive often. This is a needle that doesn't core when you put it into the abdominal wall. and you inject actually much faster because it's a much bigger needle. You need some syringes. For the baby, use a 5 cc syringe. For the bigger patient, maybe a 10 or 20 cc syringe. Some people use extension tubing, so you can focus on the needle handling and somebody else can inject. And then obviously your laparoscopic equipment, your laparoscopic procedure. And then, as I said, some surgeons have learned, depending on your practice setting, to use the ultrasound in an inline technique, and there are certain needles that you can see better under the ultrasound if you use that. The local anesthetics, you may be all familiar with that. Lidocaine works quickly, but doesn't work very long, so you can use it maybe for something, a field block around the belly button, so you can insert a trocar without pain. And then the ropivacaine, that's what I really use, 0.2%, 0.5% usually. That lasts up to 10 hours plus. And then the Exparel, it's a new medication which many hospitals, unfortunately my hospital either can't get, so I'm not using that. We have tried adjuvants. There's good publications on clotidine mixture in there for make it last longer. We haven't really had much success with that, so we're not using that. But always, you need a certain amount of local anesthetics. So you don't want to use the 1% ropivacaine because it's going to be a very small amount. So in small patients, I use 0.2% ropivacaine, and in larger patients, I use 0.5% ropivacaine. And max usually this out. So 0.5% I use half the weight, and 0.2% I use the weight of the patient, usually smaller patients, babies. Injection technique, we all know this, always aspirate before you inject. You don't want to give it IV, and the patient usually is on the monitor, so it's for safety. And the toxic side effects are very rare that something happens, but if something happens, the patient is awake, they can have tinnitus and tremors. We have observed that once. And then if you really give it IV in larger amounts, they can go into seizures, potentially coma, and cardiac arrest. And that is really dangerous. The ropivacaine has a little bit higher safety profile, and you can reverse it, and the bupivacaine is actually much more dangerous. And the antidote is a lipid infusion. So on our anesthesia crash card, probably on yours too, there's intralipid. That's what the anesthesia would give when they have a toxic reaction, so you have to know about it if something happens for you. I usually start LAP-API, for example, just a peri-umbilical field block with fast-acting lidocaine, so that can actually help putting the trocar in. And I actually ask the anesthesiologist not to give any fentanyl. And so they don't give any up front, and if they see heart rates going up, they will give some then afterwards, essentially. And then I do a laparoscopically guided rectus sheath block for the appendixes or for any kind of umbilical access. This can be done very quickly, and I usually do it from the lateral port once those are in, with some local given there. Simple to perform, you'll see in a second. This is a picture, again, reminding you of the anatomy, what you target, those nerves. And this is an ultrasound picture. If you would do it under ultrasound, or your anesthesia folks would do it under ultrasound, that's where the local has to go, where the needle is. And I mean, we are surgeons, we all know this anatomy and have seen the rectus from the inside as well as the outside. This is a laparoscopic view now from a side port, looking back at the rectus sheath. The umbilical port is kind of in the center, and you see it's very straightforward. You see the needle. This is probably a TUI needle injecting. You create a bulge back there, and sometimes you have to actually do 2 injections to distribute this adequately. We did a study to see how this distributes actually with ultrasound. But this is a very quick technique, and you need a good amount of local, but you can do it literally in 30 seconds. And I would encourage you to do this at the beginning of the surgery, because remember, the ropivacaine does take 10, 15, 20 minutes to work. And if you do it at the end, the patient may be in the PACU now, and it hasn't really started working. And then they're giving fentanyl. This is on the left is the patient just before. On the right, you see actually a little baby with a view from the umbilical port. So I usually do, when I put a little 5mm umbilical cord in the little baby, I immediately do the rectus sheath block under vision. You can see it just next to the port. And this is about 1 cc you give there, because you obviously don't have a lot of volume. In a 3-kilo baby, you have about 3 cc's of 0.2% ropivacaine, and you want to do this on both sides. But it can be done from the umbilical view, and that's how I prevent essentially babies of some trouble advancing the slides, but after 3 times clicking, it works. This is a block, the transversus abdominis plane block, TAP block, really, how everybody calls it, which is used more and more because it actually provides a little bit better coverage from data from the adult world than the rectus sheath block, and it also can be done fairly quickly. Again, same principles, try to do it at the beginning of the case, and reminder of the anatomy, the nerve runs between the transversalis and the internal oblique muscle, and there's a lateral branch, and you're trying to cover also that lateral branch, cutaneous branch. And here again, this is the ultrasound. See how lateral it is? That's what your anesthesia provider would do. And you see underneath the ultrasound needle, an ultrasound guided needle, going into the right plane, injecting some local. And you see me on the picture on the right. This is the block we do then after the umbilical access. And my fingers are on the subcostal margin because you're starting on the subcostal area, running down a few centimeters. This is a picture of this block. You see the rectus sheath on the upper edge of the screen, and the fibers of the transversalis muscle now, as I'm injecting, the local should run along the fibers if you're in the right plane. If you're not in the right plane and the needle is too far, you will see a peritoneal blister. So you know this is not just below between peritoneum and transversalis abdominis. And here you see this injection, this is more round. That is on the wrong plane. This is actually not now between internal oblique, and so the needle is advanced a little bit to get in the right, and you see a little bit lateral distribution at the very end of this video ends then. So you want to be in the right plane to inject this, and you go on several levels, every 2-3 centimeters you do this, but it can be done literally within a minute also. And somehow. And then just going one further, the ilioinguinal and iliohypogastric nerve block, you may actually do with the landmark technique, can be also done, obviously, under guidance from the inside in combination with the landmark technique, where you blunt your needle a little bit so you feel the fascia above the external oblique as well as above the internal oblique passing. There's a resistance then, injecting. But this is the anatomy, again, just to remind you. And this is the ultrasound probe again, and the ultrasound picture shows you the 3 muscle layers, and the yellow, a little bit highlighted, are the 2 nerves you're targeting. They can be seen on ultrasound, and they actually can be seen laparoscopically. When you look on the right image, I don't know if you can see it, but there are 2 white lines. One is where the needle is, that's the ilioinguinal nerve, and one is a little bit higher, the iliohypogastric nerve. That's a baby who's very thin, but you can actually see those 2 nerves shimmering through above the muscle. The transversalis muscle, and you inject right in your area the 1 cc, 2 cc you have in the baby for this block. A lot of the groin surgeons, the inguinal hernia surgeons in the adult world, they use this landmark technique or ultrasound guidance actually. It's used more and more. So pretty straightforward techniques for risk and complications, as we talked about, and you know, obviously, this is pretty safe. If you aspirate before you inject, you don't want to give it IV. That's pretty bad. But you can injure a nerve theoretically. It's pretty rare, but that's also what your anesthesia pain team always tells the patient. That's what you have to kind of tell them too. But it's a rare event, really. A little bruise. A little bit looking at the data on this. The data is really evolving in pediatric regional anesthesia blocks. And I must commend the Stanford group, the paper on the upper left. They looked essentially on laparoscopic guided tap blocks in children, compared this with ultrasound and found this is equivocal. So they had their anesthesia team do it, and they did it themselves laparoscopically, and they found there was no difference. And they looked actually with an ultrasound in the publication on the upper right, how is the distribution of my laparoscopically guided tap block? Is it in the right layer when you look with the ultrasound? And yes, it was. We looked at clonidine and things like this to add, but it actually did not make a difference. And one of the problems is probably that, if you do it for lab API and you're covering this umbilical port, you would have to have a large amount of patients to probably tease out a little difference. So that study was not successful. In regards to a rectus sheath block, the publication on the left from the left upper edge from all children's, they injected local through the small umbilical incision into the rectus sheath blindly and compared it with the rectus sheath block per ultrasound guidance and did not find a difference. However, the Northway group did find a difference in those techniques. So we have obviously, if you do it in those smaller procedures with small incisions, you have to have a large amount of patients, which few of the studies really have to find a difference. If you have a bigger incision, maybe you do an ileothecectomy or so, you have a little incision like this, the TAP block you probably need less patients to find a difference. And this Chinese group uses this for rectus sheath blocks, and they found also a difference in regards to hernias. Costs. It's always interesting to mention costs, because what costs? What is meant with this? Is it the cost to the patient? I mean, when the anesthesia pain team comes, they charge for a consult, they charge for their procedure, may get billed to the patient. The time in the OR, it takes time. The laparoscopic guided techniques are very quick. You do it yourself. The equipment is relatively, little equipment is needed, the needle and the syringe. However, you cannot charge for those blocks. I hear there's some movement potentially. The adults were talking about this, but if you do this laparoscopically guided, you cannot charge for this yourself. You can charge for an ultrasound. If you do an ultrasound guided rectus sheath block, with the learning curve is very low, very short, you can actually charge for like the abdominal wall ultrasound. Doesn't give you much, but you could. May pay for the ultrasound machine. So in conclusion, surgeons can actually perform themselves targeted regional anesthesia techniques depending on your practice setting. If you're on your own, you don't have a robust pain team, you want to save time because, I mean, my pain team, they're fast providers and very slow providers. And we may want to get 2 more patients in before my call person comes on in the night. All those blocks have a short learning curve for any kind of pediatric surgeon, facile, and have done a lot of surgery. And obviously, all the opioid things we've talked about, you want to have multidisciplinary teams, protocols based on eras to minimize any kind of opioids, perform more outpatient procedures without opioids. And the NICU, I was really happy that you're doing research in this, because if I do a hernia in the baby, usually I send the baby home on some Tylenol. If the baby goes back to the NICU, they get morphine every single time. Yeah, it's over now.